A very good afternoon, everyone. I would like to welcome each and every one of you to the free webinar on diabetes and insulin therapy, navigating the latest research and recommendations organized by the International Society for Renal Research, along with our scientific partner, BioLeaks Worldwide, and research partner, United Innovators. I would like to give a little bit of an introduction about the International Society for Renal Research, ISRR. The International Society for Renal Research is a global organization of nephrologists, cardiologists, diabetologists, researchers, and other professionals dedicated to advancing science and the practice of nephrology. The ISRR provides an international forum for scientific exchange, offering educational opportunities, resources, and advocacy in the arena of nephrology, cardiometabolic, and diabetology community. Through its annual meetings and publications, this society promotes research and clinical practices, educating the public about the impact and importance on the kidney and cardiometabolic health. ISRR also functions toward improving the quality of life for those with diabetic diseases and to advocate for better health and care and treatment. For those of you who are new to the BioLeaks community, I would like to give you a little brief introduction about the organization and welcome you all. BioLeaks is a not-for-profit professional association which prominently promotes research and development, and we at BioLeaks have brought a revolution in the field of worldwide conferences. BioLeaks brings together professional wizards and leaders who have explored all avenues to reinforce the field of life sciences and medicine technology. BioLeaks conducts events worldwide, which helps in enhancing the skill set of the people from diverse industries and forms a common platform for eminent personalities, physicians, researchers, doctors, academicians, professionals, business figures, and so many more. We work with the motto of creating a better tomorrow by organizing conferences and creating a network which will help nurture a better tomorrow with the help of advanced technology. We have scientific events happening every month in different fields of scientific research and development. And we invite you to participate and benefit from these knowledge-rich platforms. Now, we will see a little bit about the importance of this webinar. There are millions of people around the globe who suffer from diabetes, which is a chronic metabolic disorder. It is defined by elevated blood glucose levels, which can be brought on by a deficiency in insulin production, resistance to insulin, or a combination of these two. Diabetes is usually treated with medication as well as dietary and exercise modifications. People with type 1 diabetes are frequently advised to start insulin treatment, and people with type 2 diabetes may also benefit from the same. The most effective diabetes control requires being aware of the most recent findings and suggestions. The primary goal of insulin therapy is to reduce the amount of glucose in the blood by providing an outside source of insulin. Insulin can be administered via injections, an insulin pump, or it can be inhaled. Research has found that insulin therapy can be effective in controlling one's blood glucose levels, reducing the risk of long-term complications and improving the overall quality of life. Additionally, insulin therapy can be tailored to everyone's needs and can be adjusted as necessary. The most recent findings and advances on diabetes and insulin treatment will be discussed in this webinar. On that note, it gives me immense pleasure to introduce the speakers for today. Our first speaker for today is Dr. Ayush Chandra. Dr. Ayush Chandra is a consultant diabetologist and diabetic food specialist at Nivaran Health, Ghaziabad, Delhi. He also visits Nishkam Diabetes Center and Research Center in Ghaziabad. Dr. Ayush has about 13 years of experience of healthcare management and clinical practice with 5 years of experience exclusively in the field of diabetology. He has also worked for various diabetes reverse corporate companies like Twin Health, SugarFit, CureFit, MFit, through artificial intelligence, machine learning, and IoT sensors. Sir has completed his MBBS from Dr. D.Y. Patil Medical College and has an MBA in Hospital Management from London, United Kingdom. Dr. Ayush has also acquired diploma in diabetology from Liverpool Academy, United Kingdom, and fellowship in diabetes management from Indra Prasada Apollo Hospitals. He is certified in diabetes food care and footwear from Christian Medical College, Vellore. He has valued experience of working in National Health Services London, Max Hospital, and Apollo Hospital. He has an active member in the Royal College of Physicians, Edinburgh, American Diabetes Association, Indian Medical Association, Diabetic Food Society of India, Diabetes United Kingdom, RSSDI, etc. He is an Art of Living corporate yoga faculty and certified yoga trainer who conducts yoga and meditation workshops. He is an active speaker for diabetes awareness on national level and an ambassador of RSSDI. Our next speaker for today is Dr. Amit Kumar. Dr. Amit Kumar has completed his MBBS from the prestigious All India Institute of Medical Sciences, New Delhi. He did his postgraduate diploma in diabetes from Cardiff University, Wales, United Kingdom. He got his internal medicine training for 5 years in Tan Tock Seng Hospital, Singapore. He received numerous honors and awards from different organizations for his service. During his schooling, he got the President's Scout Award from the Honorable President of India. Currently, he is running his own diabetic clinic and managing diabetes emergencies excellently. He is also a consultant physician at Power Grid Eastern Region. He is academically brilliant and has delivered many lectures on diabetes control in India. He is an active member of the Research Society for the Studies of Diabetes in India. On behalf of the International Society for Renal Research, I would like to take this moment to express our heartfelt gratitude to our speakers for taking their time despite their busy schedules to share their knowledge on this important topic. So I would like to thank you. Thank you, Dr. Ayush Chandra and Dr. Amit Kumar. And I can assure all you participants that this session is going to be a very useful one for everyone who's present here. On that note, I would like to invite our first speaker, Dr. Ayush Chandra, to take over the session. And participants, at any time, if you have any questions or queries, you can put it in the chat box and we will attend to it right after each of the presentations. Over to you, sir.
Can you give me the access to open my video also? Hello? Am I audible?
Yes, sir. Yes, sir.
Video option would be there or no?
Yes, sir. You can turn on your video, I guess. You can turn it on, sir.
It's saying you can't switch on your video because the host has stopped it.
Oh, just give me 1 second, sir.
Or meanwhile, I can start?
Yes, sir. Sure. Do you need the PowerPoint?
No,
I can.
I haven't.
Okay. We can see your PowerPoint. Yes, sir. I'll make sure that your video is on in a bit, sir. Just give me a second.
Okay, no problem. So good afternoon, everybody, and welcome for this interesting session about basis of diabetes and insulin therapy, how it works. And I'm thankful to ISSR about for inviting me on today's session. And I hope you'll learn a lot of new things in today's session. To start with, what is diabetes? We'll be talking about what is diabetes, type of diabetes, etiology behind that, what are the components, how the management can be achieved in diabetes, and also what is diabetes remission. So diabetes, it is not a disease, it is a disorder. It is a metabolic lifestyle disorder which is characterized by hyperglycemia, increase in the sugar level. It could be due to low insulin in the body or no insulin in the body, depending on type of what kind of diabetes you have. Okay. So what happens, the condition of diabetes is becoming worse in India day by day. We are currently number 2 in the world right now, and after just China. And by the end of 2030, the situation can be that India can become the hub. It is already the hub, but number 1 in the world itself. So what happens, there are a number of factors which causes diabetes. First is, of course, the genetics. Second is your eating habits, sedentary lifestyle, obesity, and insulin resistance. So insulin resistance, I'll be explaining it to you. Okay, whenever we eat something and the food breaks down and it is being converted to energy. So what happens? It is not able to enter the various parts of the body. So that is the thing, the cells remit. I think cells resist the kind of this thing, and it is mainly because of this thing, lack of insulin, or there is no insulin present, and there's excess sugar. It accumulates into various parts of the body, giving various kind of symptoms, such as polyphagia, polydipsia, weakness, and muscle wasting and all. Obesity is very important part of diabetes. what happens, there is excess accumulation of fat in the body. And earlier, what happens, we used to see measure obesity by BMI, weight in kilograms by height in meters into square. So these were the categories. Above 25, it used to be the obese patient, and below 25, the non-obese patient. But now what is happening, we need to see the waist circumference. So you all can see right now what is your waist circumference, differentiating men and women. So you can just see what is your obesity level. So obesity can lead to various kind of problems: dyslipidemia, cancer risk, mood disorders, diabetes, hypertension, and liver disorder also. So it is very important to work on your diabetes, this thing, your obesity control. So diabetes, as we were talking about, is a metabolic disorder characterized by high sugar levels. So type of diabetes, it is normally like more than 40 types of diabetes are present in the world right now. And we can talk about few of them. Type 1 diabetes is simple, like it is an autoimmune disease where no insulin is produced in the body and it has to be taken from outside, which is the second important topic. I think Mr. Amit would be covering it today. Okay, what is the need if the body is not producing insulin? It has to be taken from outside. And it is normally occurring between below 30 years of children, and the condition can lead to severe also, the excess thirst, urination, weight loss, and all. And external insulin is required from day one. The patient can't survive without the insulin. Type 2 diabetes, you can define, is the insulin resistance. Okay, it can be due to insulin resistant obesity also, and it is lifestyle mainly disorder. It can be managed by oral medication, lifestyle changes, and insulin depending on how the oral drugs are behaving right now. Okay, so type 1 and type 2, as I was saying, type 1 is sudden onset and type 2 is gradual. Mostly happens in adult type 2. Patients are obese, but ketoacidosis, the DK, the rare, this thing, the emergency condition is not seen in type 2 diabetes. And type 1 diabetes is autoimmune. So these are the main differences. And the signs and symptoms: polyuria, polydipsia, and polyphagia. These are the normal symptoms. Other symptoms can be delayed wound healing, blackening of the skins, and the any kind of infection that can be prolonged. Like, where it's very important, whenever you go for the management, there are 7 parameters of management which I describe. So first is the investigation. We need to investigate the entire body. There are a number of people who says just the sugar profile will do, but I'll tell you that diabetes is connected to all the body systems of the body. It can lead to any kind of issues in the body. So kidney profile, thyroid profile, lipid, B12 deficiency, D3 deficiency, you should go to all the distinct parameters and then only suggest how the treatment will go about it. The second part is the counseling. So counseling, proper counseling about diabetes, follow-ups is very important. And here the role of a dietitian's health coach is also important in terms of a bridge between the patient and your doctor. The monitoring plays a very important role. So the first kind of monitoring is the SMBG, that is the simple glucometer measuring. It's a simple device, electronic device, which measures sugar levels. It can measure fasting, random, PP at home also, and you can carry it also. It is very important to always carry this instrument with you and monitor your sugar level. Based on your monitoring only, your doctor will decide what kind of insulin changes would you require or what kind of oral medication would be required. Same can be helpful in your diet also. The second technology which is coming in and it's going very well in India and abroad also, it is the continuous glucose monitoring. A small patch-like device which would be administered in your body for 14 days, and it takes up sugar readings every 15 minutes. Based on this, the graphs are being created just like ECG, and those graphs are being studied by endocrinologists, diabetologists, and it says, okay, there are a number of studies in it. Time in range, glycemic variability. We study these graphs and we decide the course of action. When the sugar is going up, what is the spike level? When spike levels are coming down, what is the duration? How much the sugar is in the range? So depending on that, we decide the insulin level, oral medications, whether there is a change required in the diet pattern or medication or the exercise pattern. Everything can be studied on this. Now, what is the role of artificial intelligence and this thing, machine learning? Now, number of companies which are coming practice these days, so they help the digitalization techniques, virtual consultation, and with the help of the IoT sensors, CGM, And all these devices, they create a replica what is happening in the body, and based on that they give an idea. Like the system only tells that there should be what need the dose of should be titrated, and what the changes in the food patterns is required. Now, the diabetes care is, you can divide it into two parts. The first part is the non-pharmacological, you can say, and the second is, of course, the medicine part. So, oral hypoglycemic drugs are number of drugs, number of classifications are there. So, depending on one drug, two drug, how the patient is required, the doctor decide. And again, if these oral drugs are failing, then we go into the insulin thing. So, insulin, Dr. Amit would be covering in detail what are the types of insulin and how can we use it. Now, non-pharmacological, there are a number of things which I'll be just touching them. First is your diet part. Second is your stress management, sleep quality. Then your this thing addiction should be reduced, and your monitoring part. All these things should be thoroughly improvised. These are the basic values you should be knowing, and you should be educating everybody. HbA1c test, which is being done every 3 months. So about 6.5 is the type 2 diabetes, and 5.7 to 6.4 is the pre-diabetes. Same it goes with the fasting levels, and what you can see is the random and PP levels. So these are the basic information which everybody should be aware. Now, one more important thing is this: a diabetic person goes for hyperglycemia and hypoglycemia also. There is a variation in high blood sugar levels and low blood sugar. The patient should be aware below 70 this thing level, that is hypoglycemia, low sugar level, and it can be fatal also. So monitoring is very important part. If the doses are going up, the insulin levels are going up, you need to see a doctor and reduce the sugar levels. Oh, sorry, doses of the medication. Now, complication, if I can tell you that if you are managing your sugar levels very correctly, then what happens? It can remit also, it can go into reversal also. But if you are not taking care of this thing, your sugar levels, it can lead into complication. The complication can be microvascular and macrovascular also, depending on the size of your blood vessels. So micro complication includes, it can affect your eyes, can lead to glaucoma, cataract, vision changes, kidney changes in the filtration rate, neuropathy, damage to your blood vessels, nerve vessels also. And in the macrovascular, it impacts your brain, heart, and it can cause diabetic foot also. That is a very serious condition. So diabetic foot, you can define, it's a complication in which what happens in chronic patient, if the sugar is not controlled, can lead to various problems due to reduced blood supply or the damage to the blood nerve supply. Now, what happens in the treatment of diabetes, just touching on the 7 points, very important is the diet. So in diet control, what is required is to have a balanced diet. This is the plate method which is used. So starting with you can say salad, green vegetables, and reducing the carbohydrate and protein, carbohydrate and the calorie content is very important for the better digestion also. So morning time, having complex carbs, increase of the protein content, fiber. This is very important to have a diet. Once your diet is adjusted, it is like maintained, it will have impact your sugar levels very nicely. These are just the example. Remember the ABC. The ABC of diabetes is to manage the HbA1c below 7, maintaining your blood pressure below 140/80, and also to check on the cholesterol level. So this ABC is very important. Now, walking is very important, especially after the meals. After meals, walking is very important because it reduces the postprandial levels. So, encourage your patients, your nearby people, to have a walk, and also to have exercise in the morning. Exercise in the morning will be burning the calories every day, whatever you eat. Now, monitoring, it is very important to have a logbook. Either you can go with the electronic things like the companies, Beto, Accucheck, all these companies are providing the electronic measure. Whenever you take the sugar, it automatically goes in the app. Otherwise, you should always encourage your this thing patient to have a logbook. What is the PP level, fasting levels, and all, and they should come with this report, whatever the progress has been for the follow-ups, to have a better result in that. Yoga, various kind of exercises, and especially meditation will play a very important role to reduce the stress levels, have a better sleep, and more clarity about the how the future is going to be, and live a happy life. So these are the main, you can say, steps, 9 steps of diabetes is counseling and the spreading awareness, investigation, having insulin and the medication on time, change in time, diet plan, walking, exercise, meditation, yoga, and also you can say the monitoring is most important thing. Lastly, to touch about what is the diabetes remission. What is diabetes remission or reversal? About reversal, I'll tell you the accepted term by AD and various organization is the remission. What happens is this: if the patient is adherent to the diet, physical activity, and the medicine, what happens? The sugar levels start coming down. After when the sugar level start coming down, there is the medication reduction happens. If a patient maintain this level and HbA1c is also maintained, a patient achieve a state of remission. But he or she needs to continue the same state, continue that discipline, continue the change of habits, then only that state will be achieved. So this is a big confusion amongst people of India. Okay, it can be permanently get reversed. So all these technologies, sensors, artificial intelligence can help patients and doctors to understand better condition and the progress of the patient. But we need to follow and maintain all these things in a scientific manner. So this is the thing. So thank you for the session with me. Afterwards, you can ask me question anything about the technology based and the diabetes remission, how it works. Thank you. Over to you, Bhargavi.
Thank you, sir. Thank you for your very interesting presentation. I now invite Dr. Amit Kumar. So please take over the session.
Hi, good afternoon, Bhargavi, and good afternoon, everyone. My video, can you give permission?
Yes, sir, you should be able to access it, sir. Can you check it?
No, it's still showing you cannot start video because the host has stopped it. So,
sir, I've given you co-host access. Can you accept it, sir?
yes.
Yes, we can see you now. Okay.
Yeah, thank you.
Thank you.
So let me load the slide first. Are you able to see the slides?
Yes, sir. Yes, sir, we can see the slides.
Okay, thank you. So I'm simplifying timely insulin initiation with the basal insulins. Actually, the type 1 diabetes generally needs insulin because in type 1 there is no insulin production. But in type 2 also, after a few years when there is a beta cells functions decreases, then the insulin production gets low and then patients need insulin. So this insulin's need in both types of diabetes and other types of diabetes also, like in pregnancy-induced diabetes. So I'm covering this insulin part, insulin treatment in diabetes. So the clinical scenario, as you can see, the long-standing type 2 diabetes uncontrolled on multiple OADs. So this type of patients, like I'm giving one example of Mayuri, 62 years old, presented to the physician with poor glycemic control. Further probing revealed complaints of occasional burning sensation in soul. History, he's having diabetes for 12 years and diagnosed with high blood pressure, hyperlipidemia also 4 years back. He also got family history positive for type 2 diabetes, coronary artery disease, obesity, and hyperlipidemia. And if you see the patient's characteristic, then the BMI is slightly high, 27.4, HbA1c is high, 9.3, fasting sugar is 220, PP is 294, and EGFR is 63. Cholesterol wise, it's LDL 68 and triglyceride 110. It's quite good control. And the patient is taking medicine, metformin 1 gram BD, glimepiride 1 mg BD, sitagliptin 100 mg OD. So these are the 3 oral hypoglycemic agents for diabetes treatment, and telmisartan for blood pressure, and atorvastatin for cholesterol treatment. So if we go next, like generally in the doctor's opinion, after exhausting 3 prior lines of oral anti-glycemic drugs at optimal doses, what should be the next treatment strategy for the patients? Like, should we give insulin, or we should add another tablets? So this is the main questions. And another poll is that what are the practical challenges faced while initiating patients on insulin in clinical practice? So there are some challenges like fear of injection, hypoglycemia, apprehension due to impact on quality of life, all of the above. I think all of the above is the right answer. And if we need to choose the factors in the descending order of importance that guide your decision on type of insulin to initiate in type 2 diabetes patients, like efficacy, safety, quality of life, and treatment economy. So I think the efficacy wise is the best. Safety wise also we need to think. Quality of life also we need to think. So everything we need to see. So does basal insulin have any impact on PPG excursion? PPG is like after 2 hours, blood sugar is called PPG. So it does have some role in PPG excursion also. Then what are the factors to be taken into consideration while deciding initiation dose of basal insulin? So we need to see HbA1c, we need to see body weight, comorbidities, all of the above, I think we need to see. So the clinical scenario for this Mayurish, like Mr. Mayurish got frustration and feeling of failure when informed about worsening glucose levels and onset of complication, and rejection due to perceived notice that the daily activities, including social life, may be hampered by worsening diabetes. So as I said, that rapid progression of beta cell loss continues to diminish efficacy of conventional OAD. This is the UK PDS study that says that beta cell mass reduces progressively at 4% per year with conventional OAD monotherapy. And HbA1c returns to pre-sulfonylurea initiation level within 3 years of adding sulfonylurea to metformin. So initially, the HbA1c reduces, but after that, the HbA1c rise again because of the continuous loss of beta cells. So this is the decreasing efficacy of OAD because in a meta-analysis shows that DPP-4 inhibitors showed an apparent accepted mean increase in HbA1c of 0.22% after 52 weeks of usage. And loss of glucose lowering efficacy after 2 years of treatment was observed with dapagliflozin. And a declining efficacy for SGLT2 inhibitors were also observed in meta-analysis in 2 years' time. So adding OAD beyond 3 in Indian type 2 diabetes population doesn't result in optimum glycemic control. So we can see like the patient is on 3 OAD, the change in HbA1c is 0.6, but if it is more than 3 OAD, then it is less. It is only 0.4. This is the landmark study trial. So I think if OAD failure can be defined as a clinical situation when all of the following criteria are met, like HbA1c above goal despite concurrent and optimal use of 3 OAD, adequate lifestyle control measure have been followed. OAD classes should be different. One should be metformin and the second should be sulfonylurea, and comorbid conditions causing hyperglycemia have been ruled out. So then we need initiate insulin after OAD failure. So why to initiate insulin after OAD failure? So the OADs, biguanides and sulfonylurea, are most commonly used for type 2 diabetes management. Insulinization rates inadequate. So you can see here that all the oral anti-diabetic drugs patients are taking. And then only 1 in 5 Indians has got a good glycemic control, that is HbA1c less than 7. So you can see here HbA1c less than 7 is only with 20% patients after end of 2 years. So it is only 1 in 5 patients. So rest other patients like 80% patients are having high HbA1c, like more than 7. So they are not in good control. So the complications of diabetes will be high in all those 80% of patients. So addition of insulin produce significant greater HbA1c reduction compared to that seen with the non-insulin therapy. So you can see here in the insulin, therapy, the change in HbA1c increased here after 2 years. So there is a multifaceted benefits of timely initiation of insulin therapy. Like it effectively controls the glucotoxic effects of hyperglycemia, preserve beta cell mass and function, and improve insulin sensitivity. It also protects against endothelial dysfunction and damage that cause vascular disease, provides long-term protection to end organ via metabolic memory, and alters the course of disease progression in a positive manner. Then the next question is for Mr. Mayure's patient is how to reduce the fear of insulin and its associated distress in the patients and positively reinforce behavioral changes. So the insulin conversation, insulin distress, ascertain the patient, ask questions upfront about the patient's fears, concerns, and take cues from it. Explain, help the patient understand why insulin is necessary and need to solve the problem, involve the patient insulin conversation and solve their issue. Collaborate to develop a shared action plan, identify the right regime and allow patient choice. Partner along with patients in insulin therapy to set their glycemic goal and help them achieve it. So the efficacy in management, barriers in management is fear of hypoglycemia, fear of weight gain, variability of current insulin therapy cause complications. Patients find using SMBG device painful. So the suggested solution is basal insulin, mimic the physiological action of endogenous insulin, flat profile, low intra-patient's variability, therapy linked with routine SMBG monitoring for effective use of insulin therapy. So there are some barriers also in management of insulin, like multiple dosing of insulin, inflexibility of regime, and erratic lifestyle. So the solutions are once daily administration will help avoid multiple doses and effective monitoring of patients' adherence to therapy and therapeutic modality sensitive to sociocultural factors. So the holistic glycemic control with comparable PPG reduction, significantly lower risk of hypoglycemia with basal versus premix insulin, significantly improved quality of life with basal versus premix insulin. So you can see here that at the before initiation of insulin, the glucose is from 220 to 350, and PP is also elevated fasting plasma glucose. And if we add insulin, so this part, so this PPG also decreases, fasting plasma also decreases. So the treating fasting hyperglycemia lowers the entire 24-hour plasma glucose profile, including postprandial glycemic excursions. So this is the levels which achieved after insulin therapy. The fasting is around 70, 80, and PP is around 150. So the hence fix the fasting first. This is the, you can see the landmark trials, the fasting reduced, PP also reduced from 226 to 190. And in patients with inadequate control of type 2 diabetes, initiating glargine 100 has demonstrated significant improvements in glycemic parameters. After 6 months, you can see here that adding glargine 100 to aid in Indian type 2 diabetes patients improved glycemic parameters significantly. Baseline is 9.5 in real world scenario. So from 9.5, it came down to 7.4 after 6 months. So it's a very good results after 6 months, and fasting also decreased from 215 to 122. It's almost normal. So there was a greater HbA1c reduction than compared to premix. The laptop study says that 25% greater HbA1c reduction with glargine U100 versus premix. And this is another study shows there is a low risk of hypoglycemia and weight gain with glargine compared to premix. So the lesser risk of overall symptoms and nocturnal hypoglycemia with this glargine once daily dose. And then this is also the same, the hypoglycemia, anytime hypoglycemia risk is also less with glargine compared to Mixtard or another insulins. So with the premix insulins, the patients which switched from glargine from OADs and then premix, glargine 100 exhibited better treatment satisfaction across than premix insulins. both the types of patients were taken the data, and the satisfaction ratio is more with the Clargine 100. And it's the gold standard of basal insulin therapy for people with type 2 diabetes. Although at present several options are available for insulin therapy, but Clargine 100 is still considered the benchmark in insulin therapy. And holistic glycemic control through a nearly peak less time action profile, desired control of HbA1c, and convenience of once daily administration is the another beneficial points. And Clargine 100 offers the benefit of lesser hypoglycemia, especially compared to premixed insulins. So a basal insulin regime is ideal to start. It's a simple and flexible, lower risk of hypoglycemia and better treatment satisfaction. So the optimally initiate basal insulin guideline recommendation is also from ADA and RSSDI to start the basal insulin first. And dosage recommendation for this basal insulin is if the patient's weight is 60 kg, then 12 units per day. And if HbA1c is high, more than 8, then 18 units. If body weight is 80 kg and HbA1c less than 8, then start with 16 units of basal insulins. But if HbA1c more than 8, then 24 units. And if 100 kg patients with HbA1c less than 8, then 20 units, and more than 8 is 30 units. So this is the starting dose of basal insulins according to the body weight and body blood sugar levels. So I start the Indian expert recommendation to start also with according to the 10 units per day and 0.1 to 0.2 units per kg per day. We need to start, and those to be administered once daily, preferably at bedtime. Then do self-monitoring, and dose titration should be there for the first 3 months, and monitor HbA1c after 3 months. So patients' remaining concerns alleviated, and then patient concerns with insulin extension, extreme apprehension about needles, and so initiating insulin therapy with basal insulin helps address patients' remaining concerns of hypoglycemia as well as poor quality of life. And considering patients' early apprehension, the physician decided to initiate at a lower dose of once daily Clargine at 10 units and asked to monitor their fasting once every 2-3 days and follow up after 1 week for dose modification. So the titration periods up to 3 months, and then after that, patients need to continue insulin. And the lack of basal insulin initiation titration is a reason patients do not achieve glycemic control. So we need to do active insulin titration. For each 1% decrease in HbA1c level, there is a 21% reduction in the risk of diabetes complications. So we have to be very careful about this HbA1c and need to decrease that. So this the dose titration, fasting, and the PP both we need to titrate, and then follow up to ensure success management of basal insulin that support insulin initiation and response titration. Ensure titration is occurring normally, and if not at goal, then may continue with titration for another 3 months and follow up in person or by virtual consult. So the titration is very important. Only initiation is not so much important. So the key message are timely insulin initiation can prevent beta cell exhaustion and reduce complication risk. Adding OAD beyond 3 in Indian type 2 diabetes population doesn't result in optimal glycemic control. So basal insulin significantly improve all glycemic parameters, whether it's HbA1c, fasting, and PP. And Clargine 100 has emerged over the course of time as the gold standard of basal insulin therapy for people with type 2 diabetes. Thank you very much for the kind listening. Yeah, if any questions or raise hand, you are welcome to ask.
Yes, I don't think we have any questions as of now. Participants, you're most welcome to leave your questions in the chat box, or you can also raise your hand so we can attend to the questions. Yeah, before that, I want to thank you, sir. Thank you, Dr. Amit, for your very in detail presentation.
Yeah, welcome.
Okay.
Someone, Devesh has raised
yes,
hand.
sir. He's raised his hand. I've Yeah, so you can talk now. I think you can unmute yourself and you can ask your questions, sir. Mr. Devesh. Mr. Devesh, you are one of the panelists. You can ask your question. Both the doctors are available right now. Or in the meantime, Dr. Abhishek, I promoted you to panelist, so you can ask your question now, sir.
Good afternoon, sir. Thanks for
Hi, good afternoon.
nice
Yeah.
presentation, sir. It was very elaborate and very methodical, sir. Thank you again. Sir, one query to you, sir. Supposedly, a patient on diagnosis is coming out with an HbA1c of around 10. Can we consider insulin as a first line agent?
Yeah, according to the guidelines, we have to see the ADA guidelines. If you see that patients has got any complication, any the glucotoxicity effects, then we can start. You can start insulin if HbA1c more than 9. So this is the guideline by ADA and RSSDI also. So you have to assess the patients clinically also. If the patient is like having DK, HHNK, or anything, and HbA1c is 10, you have to start insulin. If the patient is not glucotoxic, it's a normal, no symptoms, no toxicity. If you can see, then no need to start also. You can add oral hypoglycemic agent also only.
Sir, one more query. Sir, keeping in mind the incidence of beta cell inertia, sir, where would you place glimepiride in today's world, keeping aside the cost effectiveness?
Glimepiride, I think now a newer oral hypoglycemic agents has come. So first line, we always add metformin according to the guidelines. And if the for the second line, we are having newer oral anti-diabetic medications like SGLT2 inhibitor, DPP4 also. So we can, I think we should avoid, generally I prefer to avoid sulfonylureas. Yeah.
Sir, one last query. Sir,
Yeah.
Nowadays we have seen the emergence of vildagliptin once daily 100 milligram doses. Sir,
Yeah.
keeping in mind the pharmacokinetics and pharmacodynamics of the various DPP4 inhibitors, including vildagliptin, sir, how rational do you think it's 100 milligram OD vildagliptin?
I think if you see the pharmacokinetics, the effect is only for 12 hours, not more than 12. But I think their preparation is like sustained release or something they are saying. So I'm not quite sure, but if we see the HbA1c after giving because we have seen patients taking vildagliptin 100, it's not getting high compared to the BD doses. So many doctors are using. Maybe their preparation, I don't know how they are preparing and making it like a slow release or something. So it is possible if they have done some, I think, biomolecular engineering type something. So if they are making a sustained release, then obviously, yes, they can be effective for 24 hours.
Okay, sir. So thank you for the nice presentation and thank you for answering my queries. Thank you, sir.
Thank you. Welcome.
Thank you, sir. We have another question from Fasi Shaikh. The question is, what's your opinion on stop using or taking sugar? Is it helpful? And he's also asked if brown sugar can be beneficial. The question is open to both the speakers. So whoever
I think Dr. Ayush
wants
can
to
go
address.
ahead
sure.
with this. Yes.
Okay, no problem. So the thing is this, of course, you need to restrict the sugar levels, the sugar or all the sugar items. processed items, bakery items, and even the fruits. But the important part is this: you have to restrict your calorie content and the this thing carbohydrate. That is very important. And it is good that change from white items like white rice, white sugar, white bread to brown items. They have low glycemic index. That is one. And second is the thing use of correct artificial sweeteners would be very much recommended. All those which are recommended by FDAs like stevia, sucralose, all these things is recommended. So go for the FDA approved ones, and of course see the thing sugar content, the calorie content in the food, whatever you are eating. Okay.
Thank you, sir. The next question is from Sai Sudha. She thanks you for the presentation. And the question is, insulin is compulsory for gestational diabetes. So daily dizziness is symptom of diabetes during pregnancy.
So, yeah, I think the insulin is really needed in pregnancy because most of the oral hypoglycemic agents are causing side effects to the fetus. So generally the pregnant patients should take insulins. But nowadays metformin is also, the study shows that it is having very less side effects on fetus. So nowadays oral tablets of metformin is also prescribed. It's included. Yeah, so I think insulin is still, I think, the choice of medicine, choice of a drug in the pregnancy. But metformin is also patients can take if they, yeah, if it is controlled by the metformin, then no need to take insulin.
Thank you, sir. The next question is from Dr. Dhanalakshmi. Can you suggest the treatment for type 1 diabetes other than insulin?
I think, Dr. Ayush, you want to go ahead?
Yeah, sure. So the only thing which we were speaking earlier, it is an autoimmune disease, and the patient has to be on insulin forever. That is the thing. Okay, so but we still have some tests like C-peptide and all. We see how much are the beta cell reserves, but the only thing is this: okay, the primary treatment is the insulin therapy, and depending on your doctors and how the condition, the pancreas reserves are there, depending what insulin is required for the patient. Even though some cases the oral drugs are required, but the primary can be given, but always insulin therapy is recommended in type 1 diabetes. Dr. Amit can add more if you want.
No, I think you said rightly. I think insulin is still the only options till I think till the next, I think, research or something new come for the type 1 diabetes treatment. Till now, insulin is the only best options for the treatment.
Thank you so much, sir. Are there any more questions from any of the participants? If you have any questions, you can quickly raise your hand or you can type it in the chat box. Any questions or clarifications that you want to ask Dr. Ayush or Dr. Amit? All right, then. Okay, sir, I want to thank both of you, sir, again for taking all the questions so patiently. We've reached almost the end of the webinar, and I just have a couple of, oh, sorry, there's one more question. Sorry, it's a question of Devesh. Can sugar patients donate blood?
Yes, I think sugar patients can donate blood until if the patients is like not very high or not in ketotic stage, not in the patients can give yeah,
well controlled sugar levels.
Yeah,
that's good.
Sure.
Okay, thank you, sir. So again, coming back to a couple of things that I wanted to share. So there's going to be an upcoming webinar. It's a free webinar too on dialysis and renal transplantation. It's on the 31st of March. So you will receive details about that, and the certificate for this webinar will also be shared to you via email. And if you have any more queries, you can contact Bhargavi, the actual Bhargavi, which is not me. And also, Okay, with that, we are signing off for the evening. Again, I want to thank Dr. Ayush Chandra and Dr. Amit Kumar for taking your time and sharing your valuable expertise. And we are not leaving yet. Just give me one more question has come up. Okay, the question is from Ms. Reshma. Chronic use of sugar substitute like sterviol does it lead to kidney impairment?
I think the recent there was some study from the I think USA already. They have says that the side effects of all the sugar substitute is there, so it is really not very helpful for the diabetic patients, and we should try to avoid this. And yes, it can lead to some kidney damage. The recent study I think just published last month. Have you seen, Dr.
I would,
Ayush?
I would say use minimum amount. That is fine. If you are having so much craving for like tea, coffee, which is very common in India, so little bit amount of this it is good, but we should avoid having a habit. Every day we are having every day two morning, two night. So whatever minimum you can do, that to only the approved one, that would be okay for now. And lots of people use it in other food substitute sweets also. It goes same with that also. So minimum use is what I can say.
Yes.
Okay, thank you. So just one question from my team. The question is, does diabetes cause skin infections? In such a case, if it does cause skin infection, then how do we cure it?
It
Yes.
is not. Please go
Yeah.
ahead.
Yes. Go ahead, Dr. Ayush. I think.
Okay, I'll just say as I told uh, any kind of infection, if it is there in the body and you are having diabetes, then the chances of reoccurrence will increase. Even though if you will take some symptomatic treatment, going for a dermatologist consult, it will be cured, but again it will come again and again because the infection, you can say the high sugar is there in the blood. It is very important to improve the root cause, that is the diabetes, and to reduce the sugar level. Then only skin infection, various skin infection it happens, will improve. Over to Dr. Amit.
Yeah. Yes. Right. I think any chance of infection, the risk of infection is very high in diabetic patients compared to a non-diabetic patients. So you can just imagine that if any patients, like if you are a normal person, there is a risk of a skin infection. Then in diabetic patients, the risk is getting more. So it's always there in a diabetic patients.
Yeah. Thank you, sir. Thank you so much.
Yeah. Well,
Yeah. Once again, thank you, sir. And special thank you to all the participants for making the webinar very interactive and an interesting one. Thank you all so much. And we all hope to connect again soon. Thank you all so much. Have a great rest of the evening.
yeah. Thank you. Same to you. Thank you.
Thank you, sir.
Prayush.
Yeah,
Take
thank
care.
you, Dr.
Bye.
Amit. Thank you, everybody, for your time. Bye-bye.
Bye, Bhargavi.
Bye, sir.